go out the exit and just turn to your left. There's a quiet room set up for you there. If you find that you just need to get away and gather your thoughts based on having heard something that may have affected you. And also, I would ask each and every one of you, if you notice that someone needs some quiet time, please don't let them go out by themselves. Make sure that there's somebody there with them, sitting with them, listening to them, helping them out, seeing that they can come back. And with that said, I'd like to introduce Dr. Vedelago, Chief of Addiction Medicine Service, and Wendy Psych Clinical Manager from Homewood Health Center, and they'll talk about after the debriefing when serving continues to hurt. Here we go.
Okay, well, thank you. Thank you for that introduction, and I just want to start off by thanking the folks at Badge of Life for inviting us back again. We did one of these events back in October, and it's great to be involved in this organization. So Gary did do a little bit of an introduction for us in that he let everyone know that we're from the Homewood Health Center. And just want to let you guys know that's the perspective we're going to be talking to you from today. Dr. V and I both work in the addiction medicine service at the Homewood, which means we work in a residential treatment program. We work with individuals who are seeking treatment for both addiction, and we also have a program for individuals who have both addiction and post-traumatic stress disorder. So it's from that perspective that we're going to be talking to you today. I also do a group for uniformed professionals, so I'm hoping to share maybe a little bit of what I've learned from working with first responders. So that being said, as you all know, the work that first responders do is the type of work that has its dangers. It can result in physical injuries, and it can also put people at risk for emotional or psychological injuries. Now, we try to minimize, to the best that we can, the negative effects that the work has on individuals. However, no matter what we do, we can do a lot of stress debriefings, a lot of self-care, a lot of resiliency training, but despite that, if the right event happens at the right time, or the wrong event happens at the wrong time, no matter what we do, everybody is at risk for some sort of injury. So in our presentation today, we're going to talk to you a little bit about two potential injuries, one being addiction, the other possibility being post-traumatic stress disorder. Now, if you're going to talk about one of these disorders, you really need to talk about the other. And that's simply because the two disorders tend to coexist at a very high rate. If you look at individuals seeking treatment just for addiction, you're going to find that at least half of them also report some sort of PTSD types of symptoms. Likewise, if you take a look at individuals who are looking for treatment for PTSD, studies have shown that up to 75% of these individuals also have an addiction problem. This co-occurrence holds true no matter what population you look at. If you look at older people, it's there. If you look at younger people, it's there. Men, women, civilian populations, veteran populations, it always seems to be there. And in fact, a number of years ago, or maybe about, when was it, in 2011, Dr. V and I also did our own study taking a look at individuals in our treatment program coming in just for addictions, and we found pretty much what the rest of the studies found. We found that just over half of the individuals in our study also met criteria for PTSD when they first came in. So that's pretty much something that seems to hold no matter what population we look at. So I'm going to talk a little bit, or we're going to start with post-traumatic stress disorder. And whenever I talk about PTSD, I always like to start off by talking about trauma. I find that today, when we talk in everyday language, there's a tendency to overuse the word trauma. In our everyday language, a lot of people now talk about trauma as if they're referring to extreme events. For example, people will refer to things like losing a job, failing a course at school, the end or the breakup of a relationship as a traumatic event. For sure, these events can be profound in that they have lasting effects on people's lives. They're extremely upsetting, but they're not traumatic. When we talk about trauma, we're talking about events that involve witnessing or being directly involved in events that involve death, serious injury, sexual assault. Sorry, I'm losing. We're talking about either witnessing this firsthand, having it happen to somebody very close to us, or, and oftentimes this may be through occupational events, having repeated exposure to the details of such an event. Some examples of these events are things like natural disasters, accidents, exposure to toxic substances, captivity, definitely war zone exposure. And these are just some examples of events that would be considered as traumatic. And as you can see, for most individuals, at least for us living in North America, for most individuals, as Gary pointed out, we experience very few of these events if you're a civilian. However, if you're a first responder, these events may be so commonplace that when your partner asks you at the end of the day, "How was your day?" you may not even think to mention some of these events. That's because you're exposed to it either directly or witnessing, or simply because you're needing to testify about it and talk about it over and over and over again. You're exposed to it to that degree. Now, what happens to individuals when they have that kind of exposure to these kinds of events? Well, for most people, first responder or not, you're likely to have some sort of emotional, cognitive, behavioral, or biological distress immediately after the event. So this can include things like, having those memories, having some images kind of come back to you when you're not purposely looking for it. You might find yourself having some restless sleep, a little bit of anxiety or apprehension, or you just find yourself like not wanting to go to places, just kind of being a little bit more reclusive than you normally are. For most people, these difficulties will be, or most of the time, these difficulties will be quite mild. You'll put up with it for a couple of days, maybe a week or two, and then over time, it'll kind of subside. For other people, it might be a little stronger in that for a period of time, maybe you have a hard time getting out of the house, it's quite severe, and it may even get to the point where you get diagnosed with something called acute stress disorder. Either way, in most cases, within a couple of weeks, definitely within a month or so, these difficulties kind of subside and people kind of return to normal functioning. But that doesn't always happen. For other people, or maybe you've had it kind of go away, and then one day you find it's not going away. You're starting to have some longer-term dysfunction or some longer-term problems related to some of the stuff you've done or some of the things that you've seen. What may happen is that it persists beyond the 1 month point. Individuals may go on to develop more serious medical and psychiatric problems such as major depression, generalized anxiety, maybe you develop a simple phobia. And for other people, they have a substance use disorder or post-traumatic stress disorder. And I also want to note that even though some of the numbers show that for men, a substance use problem is the most common thing, and for women, it rates as number 3. Some of the more recent studies are showing that ladies were catching up. A lot of the studies are showing that it's actually number 2 for women now, and may not be so long before it becomes number 1 for women. So in that way, we're catching up, and obviously not in the best way that we'd like to. So part of the requirement for sorry, I just jumped ahead here. So I was going to start off by talking about post-traumatic stress disorder, and I'm not going to go into a lot of details about PTSD. I think probably most people in this room have some familiarity with it, and I think we're probably going to be talking about it a little bit throughout the day. But just to highlight some of the symptom categories, intrusive symptoms. That's the flashbacks, the nightmares, and I really want to emphasize that when we talk about the intrusive symptoms or the re-experiencing symptoms, we're not talking about remembering something. We're talking about remembering to the point of reliving. So what often happens with people is that the emotional centers of the brain get activated, the sensory motor systems of the brain get reactivated. When people are, quotes, remembering, what's happening is that they're having full emotions. They're having sights, they're having smells, they're having sounds, they're having tastes. And that can be quite disturbing. We're also talking about avoidance symptoms, keeping away from things that may remind you, some changes in mood, maybe you've got too much feelings or finding yourself emotionally numb most of the time. Some of the cognitive symptoms, having some really black and white thinking about the world and the people around you. So things like starting to see everybody in your environment as either being a victim or a perpetrator. Or for those of you who are familiar with Gil Martin's work, this would be part of the place where you start to see or consider everybody an asshole. Everybody lands up in a category, black or white. Some of the other symptoms may be the hyperarousal symptoms or that startle response where, even when your refrigerator motor kicks in, you find yourself having a little bit of a jump, a little bit of a startle response. Now, these symptoms need to be present for at least a month, and part of the criteria for the diagnosis is that it's also interfering with your functioning in some way. So when we talk about impairments in functioning, it can be all kinds of places. It can be things like finding yourself getting into a lot of arguments with people. Maybe you find yourself being snappier with your kids, with your dog, start lashing out at the Walmart greeter when you go grocery shopping. You might find yourself doing things like avoiding going to the gym because, there's just too many people there. All the noises are starting to bother you. If you look at the list of impairments that I put up on the board, what you'll see is that I did not include any work-related impairments. And I did that quite purposely. I did that because for first responders, as well as healthcare professionals, work-related impairments are actually the last things to show up. First responders tend to be so responsible and so tied to what they do for a living. I mean, that can be such a big part of your self-identity and your self-esteem that when you do start to have some difficulty, all energy goes into maintaining that work role, to maintaining that ability to serve. That work life is the last place where you'll start to see people starting to, quote, slip. So when you do start to see a colleague or within yourself, work-related consequences of the work you do, it usually means that the operational stress injury, be it a mental health problem or an addiction, it's usually well entrenched at that point in time. So what are people doing to try to maintain their work role? Well, they use all kinds of different coping strategies. Some of them are quite healthy, some of them not so much. And a lot of what determines whether or not something is healthy is the extent to which we may be doing it. So, sleep, food, exercise, those are all healthy, but if that's the only coping you have, well, maybe it's not so healthy. For some people, they're able to do some of the emotional expression and have some healthy outlets. For other people, they'll turn to drugs and alcohol as a way to cope. And why not? Why not use drugs and alcohol as a way to cope? Historically, we use drugs and alcohol to cope with all kinds of physical ailments. Why not use alcohol and drugs to cope with some of our emotional difficulties? For example, just in terms of how long-standing drugs and alcohol have been in our coping. Anybody here ever have a bad cough? Maybe you had bronchitis? Anybody ever think of using heroin? This is an ad from, I think, 1903. Heroin, made by the F.E.A.R pharmaceutical company, was once a cure for coughs. Okay?
Try not to cough, guys.
Everybody lands up coughing at this point in time. Okay, here's another one. Anybody ever struggle with fatigue, exhaustion? Maybe you've done just a stretch of nights and you just can't get yourself moving, can't get yourself going, and you need something to help you out. Here's another ad from the Coca-Cola company. Tired? Then drink Coca-Cola. It relieves exhaustion. Anybody know why? That's right. Original Coke, not new Coke. Original Coke had cocaine in it. So magically, somehow, it helped people with fatigue. One more. Anybody hate going to the dentist? You know, you get that toothache, it's bugging you, it's bugging you, it's bugging you, and you just avoid calling the dentist. Cocaine, tooth drops. Instant cure for toothaches. Works instantaneously, and apparently, I think somehow it's less painful and a lot more fun than going to the dentist. Okay? Well, yeah, you know, children, they tease, right? Okay, so those are some fun examples, or some interesting examples of the role drugs and alcohol have played for us and when we experience distress. And just as we have used drugs and alcohol as a way of coping with physical distress, we often use drugs and alcohol as a way of coping with emotional distress. And when people talk about the reasons why they use drugs or the reasons why they use alcohol, it actually makes a whole lot of sense. People will talk about using drugs and alcohol as a way of helping them fall asleep at night. They'll talk about it in terms of helps them regulate their mood, lets them be a little less angry so that they can do things like go to the grocery store or attend those parent-teacher interviews that they find so distressing because, you know, I don't want to be with all those people. And the weird thing about drugs and alcohol is that all the reasons people give for using, it's actually true. A lot of this does work. In the early stages of PTSD, anything you do, including alcohol use, does help with the PTSD symptoms. Anything you use that helps you bring down your central nervous system functioning does help to improve PTSD symptoms. The problem is that even though initially alcohol helps by decreasing your hormonal response to stress, it decreases the production of things like cortisol and other stress hormones, which helps with PTSD. In the long run, what also happens is that it stops you from being able to extinguish the emotion, be that fear or anger or helplessness. So what happens is you need to keep using, because every time that memory gets activated, that fear response, that anger response stays just as intense as when it first started. So because that keeps happening, the person needs to use more substance, needs to continue to use that substance for a prolonged period of time. And with prolonged use, the person runs the risk of developing either an alcohol use problem, an alcohol dependence problem, or a full-blown addiction. So I'm going to have Dr. V come over and talk a little bit about the difference between the three types of use problems. Go ahead.
Can you hear me there? Okay, I'm gonna. Can I just put this here, maybe? Oh, this isn't gonna work out well. Hi, folks. I'm Dr. V, and I'm an addiction doc. There's not many of us in North America, so we're kind of a strange bunch. Now, does anyone know what this is? This is a prescription for alcohol. Like I said, one of the things about addiction, the beautiful thing is that bad ideas never go away. They just come up again and again. Back in the 1920s, if you had any nervous condition, any health conditions, you can get your doctor to write your prescription for alcohol. And it was great. It was the cure for everything that life ails you. Unfortunately, it did do a lot of damage during that time. And with when they repealed prohibition, you don't see prescriptions for alcohol anymore. As you know, one of the things is the longer I stay in medicine, it seems that history is repeating itself. I know my colleague, Ms. Wu here, just talked about heroin. Do you know now in Canada, for the first time since 1914, as a physician, I'm able to write a prescription for heroin? That seemed almost absolutely inconceivable. It was scheduled as a very dangerous drug, but I can do that now. Also, being in the addiction medicine service at the Homewood, we are like the canary in the mine shaft, if you will, the coal shaft, because we treat over 1,000 patients a year. One of the things that we are seeing is the devastating effects of cannabis. I was just recently at the Canadian Society of Addiction Medicine. It was an international society also, and many of our international brethren and American brethren in addiction medicine are also starting to see the same devastating effects of cannabis. And once they legalize it, which I hope they do in one way, take it out of the medical profession, because that's not where it belongs, then I think you're going to see the problems quite severely. That's a tsunami that we're starting to see right now. And it has particular importance, especially in PTSD, because what the research has shown is that it prolongs symptoms. It traps you. And that's one of the things that addiction is very good at doing. Let me show you. First of all, I want to tell you there's different levels that we look at. There's abuse, dependence, and addiction. All of these can be very dangerous, there's no doubt. Abuse, time limited. Sometimes you go out on a weekend and you drink a lot, and you get drunk and you fall down. That's abuse. Eventually, people start to say, this is not a good idea, and they stop. Dependence is a normal body response to an external substance. So if you go to your doctor and he puts you on, let's say, morphine for 2 weeks, you will become dependent on it, I guarantee you. But does it mean that you're addicted? No. Addiction is a very, very dangerous, actually genetic disease that when it gets triggered, traps the individual in a cycle of inability to control the use or stop the use. And eventually it's quite fatal. Actually, in Stats Canada, death from alcohol and drugs, and this didn't include smoking, approximately 1 Canadian will die approximately every 32 minutes. Now, what addiction is not a symptom? Certainly abuse and dependence can be, but it's not a symptom. It's not a behavior. It's actually genetically mediated change in brain chemistry. It's genetic, far more genetic than hypertension, more genetic than diabetes, and more genetic than actually breast cancer. That is now known. And it isn't just a form of self-medication. It starts out that way. Let me tell you, substances will tell you what it'll do for you, but it'll never tell you what it actually will do to you. So yeah, it really works. The thing is, when it stops working and actually makes your life worse, makes any condition you have worse, and you can't stop, you know it's gone beyond just any self-medication. Now, what defines this disease and why, especially in our unit, we have a special program for an integrated PTSD and addiction program, and also one for first responders, and why it's so important, because addiction is defined by something that is known as a craving narrative. And what is the craving narrative? Craving narratives are actually something that occurs, a genetic change that occurs in your brain that develops a story that makes sense for you to go back to using again, despite the devastation that the use has caused in your life previously. The way it works is and this is just adapted from Wong et al. From the UK, drug use and any traumatic event, they work tandem. You need some kind of event or a switch. Will cause changes within the genetic structure, causes gene modification, and develops a stable memory pattern, a narrative that is active and makes quite a bit of sense in order to go and use again, even though it is destroying your life. Just to show you this is adapted from Nestler. Eric Nestler had a chance to meet this individual. He's a researcher in the United States. And just to show you that what happens is when the drugs and alcohol enter your brain, starts a change in the genetic structure that leads to actually new formations in the brain. Genetic formation in the brain. See, at one time in medicine, we thought what you had in your brain is what you got. That's not true. Actually, the brain is quite dynamic. And it starts to develop circuits, especially in the areas in the frontal cortex. And the frontal cortex is a part of your brain that tells you what you're doing isn't a good idea. And it shuts it off and puts in there a stable memory pattern that says, you know what? Use again. That's what's going to help you with your PTSD, let's say. But then you wake up and you find out it's even worse. Then use again. The hallmark of addiction, as I pass the mic back on to my colleague, is the craving phenomena. And the craving phenomena, which is really misunderstood by many clinicians, is actually a narrative, a stable memory pattern that we can see in actually real-time functional MRIs that makes sense to the individual to go back to using. And what does it incorporate? It incorporates memories and emotions. And this is why it's so important to treat both addiction and PTSD together, because PTSD brings with it emotions and memories that are quite profound.
Excuse our public moment here. So as Dr. V said, the hallmark of addiction is the craving phenomena or the craving response. And with PTSD, there is also a hallmark, the hallmark of PTSD being the phenomena of re-experiencing the traumatic events. Now, when you get the PTSD and the addiction co-occurring, something very profound happens. What happens is the addiction, over time, eventually hijacks the trauma history. What it does is it takes the flashbacks, the intrusive recollections, the trauma-based beliefs, and the hyperarousal symptoms, and it uses all these memories, all these symptoms as material for the craving narrative. So the trauma history becomes part of the addiction craving narrative. That is the story that the person tells him or herself that makes it absolutely, positively make sense to continue using, to continue picking up that next drink or that next drug, despite all the negative consequences and all the devastation that using leaves behind. And with time, the addiction and the PTSD become so intertwined that not only are they coexisting in the brain and behaviorally, in terms of the behaviors that the person is exhibiting, but any attempts to just extinguish or to address just one of the two disorders merely serves to accentuate or worsen the other disorder. So for this reason, for individuals who are struggling with co-occurring addiction and PTSD, it's really essential that any treatment efforts, any efforts to get any help, are addressing both disorders and addressing it in an integrated fashion where the two disorders are being helped in terms of being provided with some coping mechanisms to deal with each, but also where the codependent relationship between the two disorders is also explored, because they're extremely intertwined in the brain. So I just want to spend our last couple of moments talking to you a little bit about some observations or some of the things that we've experienced in our treatment of first responders. Like I said earlier, I've been doing for a number of years now a group for uniformed professionals. These are uniformed professionals, first responders who experience either just addiction or right now addiction and PTSD. In the past I did one for individuals who had PTSD only. And coming into treatment or accepting the fact that you need some help, that you need some treatment can be really difficult for first responders. And for the individuals who come into our treatment program, it's probably a little bit more difficult because we are a residential treatment program. And because we don't live in the States where they have the ability to have specialized programs for just about everyone, most people in Canada, most first responders in Canada, if you're going to go into a residential treatment program, you're going to be going into treatment with civilians. And that poses some challenges. I think it can offer a lot of opportunities, but it also poses some challenges. Being able to go into treatment, first of all, and be expected to do the emotional work that Gary talked about earlier, that's a challenge in that part of the training is to be strong, to keep your emotions behind you, suck it up. And then you find that you walk into a treatment program where you've got a psychologist or a therapist or somebody like me asking you every 2 minutes, how does that make you feel? I don't want to know how it makes me feel, much less tell you how it makes me feel. Yeah. So that in and of itself can be difficult. But then going into treatment with civilians can be difficult in that we're asking you how you're feeling, but part of that is you're going to have to give up, kind of drop lower that first responder persona, that sense of strength. And that can be hard because a lot of first responders will go into treatment and continue to be cops, continue to be first responders. They'll go in and continue to be rescuers, looking around, trying to see within the treatment community who needs my help, who's vulnerable, how can I help you today? The other thing that can be really difficult is just sharing. In an environment like this, it's difficult, but sharing in front of civilians can be difficult. People are often afraid of contaminating the people around them with some of the stories that they have in their head, some of the experiences that they've had. So these are all challenges that people are going to have to kind of work through in getting treatment. I think a lot of the challenges also happen on a systemic level, right from the top to the bottom, right up to the top again. I first started working with first responders. Actually, I started my work in this area, started working with soldiers back in mid to late 1990s, and have had the opportunity to continue that work with soldiers, corrections officers, all kinds of first responders. And even though we've made a lot of inroads in terms of being able to accept emotional injuries as injuries, there's still a lot of work to do. Not too long ago, I threw out the question to some of the guys and girls in one of my therapy groups, asking them, what's it like for you? How hard is it, or is it hard for you to accept the fact that you've been diagnosed with PTSD? And a lot of these people had actually had to fight